For today, we are going to look at evidence-based medicine. Our moderator today is Dr. Maria Wanyonyi, a consultant ophthalmologist practicing currently at Gichuhi unit. And I'm going to invite her to invite our speaker for today. Karibu Daktari. Dr. Maria.
Thank you, Dr. Kalu. Now, good evening to you all, and welcome to today's session of OSK CME, whose theme is public health. So most, if not all of us, are seeing patients on a regular basis. And when you look at your practice of ophthalmology, how much of it is based on published research? And how much of it is based on experience, whether your own or other people's experience? And what other factors do you consider when managing your patients? To guide us in finding the answers to these questions, we have our presenter, who is Dr. Stephen Gichuhi. Dr. Gichuhi is the chair of the Department of Ophthalmology at the University of Nairobi. He also has a Master of Science in Epidemiology from the University of London, the London School of Hygiene and Tropical Medicine, where his PhD study was titled The Epidemiology and Management of Ocular Surface Squamous Neoplasia. He has also been a senior research program coordinator at the Johns Hopkins University. He has published numerous peer-reviewed scientific papers and supervised master's dissertations to completion. He's been a journal peer reviewer in both local and international journals. And finally, he's one of the editors at the Cochrane Eyes and Vision Group. Now, that's part of the Cochrane collaboration, which does systematic reviews to facilitate evidence-based choices in healthcare. So Dr. Gichuhi will take us through our topic today, which is the evidence-based medicine in Kenya. If you have any questions, you can put them in the chat box. And at the end of the session, I will read them out for Dr. Gichuhi to answer. So welcome, Dr. Gichuhi.
Thank you very much, Dr. Wanyonyi, for the kind introduction. And thank you, OSK, for giving me the opportunity to share on this topic. So if it's okay, if I could be allowed to share my screen, we'll get going.
Please go ahead, Daktari.
So thank you. Today I want us to just have a few minutes to just share on reflections. We're not going to discuss complicated epidemiological material or anything like that. We've had previous sessions in other years where we've done that in a little more detail. But I'm hoping that today we can have a more reflective discussion, especially at the end, over this subject. I know the main topic was public health, but I also want to make it clear that evidence-based medicine extends beyond public health. It can go into clinical practice as well. In fact, there are people who prefer to use the word evidence-based practice rather than evidence-based medicine. But be that as it may, it's a subject I find very much enjoyment in. I'm very passionate about this. And let's get on to the subject. What is evidence-based medicine? The classical kind of description revolves around these three issues. It's a conscientious and judicious use of current-based evidence, but together with clinical expertise and patient values to guide patient care decisions. And so evidence-based medicine is in the intersection of those three. There's a tendency for people to think evidence-based medicine just means using epidemiological material and research evidence. But clearly it's not just that. It's being able to, you can't put away your clinical expertise, but also the best research and your expertise cannot be put into practice in a patient who is unwilling or uninterested in what you're offering. So we also have to consider the patient's values. We also have to consider their preferences. The best decision in a certain situation based on the patient's preference may not necessarily be something related to the current or best published research evidence available. The process basically, and whether you're looking at a patient or whether you're making a public health decision, starts with asking a question. And there is generally a way of phrasing questions so that you often hear things like PICOS or PIOS, and PICOS is just an acronym for, if it's a clinical setting, the P is for the patient. Who is the patient? And usually if it's an intervention you're thinking of offering, what is the intervention? And then the C is the comparison. What else could you do instead of the intervention you have in mind? And so the O is the outcome. So after you've given this intervention, what outcome are you looking for? And the S is usually the study design that's best for answering that question. For public health, is probably more applicable to say POs, the population in mind. Sometimes it's the exposures that you're interested in, and what is the outcome of those exposures, and what are the best study designs to find information that will help you answer that question. So then you go ahead and access the information. And the information can be accessed a lot online these days, using your cell phone, using your computers. But not everything, just because it's published, is good quality. And I think anybody who's attended journal clubs knows that we've seen and critiqued articles published in what would be considered highly reputable journals, which we found wanting in some way or other. So there's a formal way of appraising this evidence. Then you apply it either on the patient or on the population. But you must keep evaluating. And I think the COVID epidemic has taught us a lot about this. Both the good use of evidence, and sometimes you see the lack of use of evidence, and quite often that last step, evaluating what happened before, it doesn't happen in many settings. But a good clinician always keeps checking on his patients. You change your surgical technique from this to the other. What is the outcome? So keep evaluating what you're doing. So generally that's the process. But some people ask, so why do we call this thing evidence-based medicine? Isn't that what we've always done? And quite often it makes interesting discussion to say, so what else influences medical decisions? So it's not always evidence in terms of good research, clinical evaluation, and listening to patients. You've all been in settings where sometimes the most senior people carry the day, what people sometimes like to think of eminence-based practice. Something will be done just because so-and-so has said it. And usually, especially the senior people, tend to believe that their experience overrides whatever current evidence exists. We also know that money is a big influencer of decisions. Whether the availability of it or the possibility of making money from offering a particular treatment, but also the opposite. The lack of money can actually influence what decision will be offered, because you may not afford, or the patient cannot afford what is being offered. These days, especially media is a big player in influencing decisions, and people know that. Just because something appears in the press makes it sound valid. So, people quote a newspaper article. If I appear on the Nation newspaper tomorrow saying something or giving a talk on something, somehow that seems to give credibility to the fact that he's a doctor talking about this and this is what he said. And especially with COVID, you've all received WhatsApps of what was said in this media, in that TV channel, and in whichever talk, even in TED Talks. TV and social media, a big influence these days. And, influence can be good, but influence can also be manipulated. There are people who also like to think of vehemence-based practice. The person who shouts loudest and argues the most, people sometimes will give in just for peace. Then there are others who like to talk about eloquence or elegance. There's the person who is a very elegant speaker, somehow convinces everybody, political kind of influences. There are also others who throw their hands in the air and say, shauri ya Mungu, providence-based practice. And the decision is best left in the hands of God. And others talk about diffidence-based practice, you're too timid to make a choice, and so you decide not to make any choice at all. This next one also is very common, especially with young doctors. People are afraid of litigation, so you over-investigate, you over-treat patients. And the last one, probably not very common in our field, but maybe I could think of other disciplines of medicine where there's a lot of confidence-based practice, bravado, some people who walk around talking about, this operation, these patients in my hands, this is the outcome I see. And, people who are pretty gung-ho and very confident about trying something new, whether there's evidence for it or not. So these things could also influence medical decisions. And later on, we'll see how some of them come to play. So what drives this whole movement of evidence-based medicine? This is not in any order of importance, but I would think, especially in our setting, financial constraints have become a big thing. So that people are wondering, I can't afford this medicine, but is there another medicine I could use? Or I can't afford to have a PET scan. Will a CT scan find this tumor we are looking for? Or I can't afford to have this operation. So what happens if I don't do it, doctor? So financial constraints are a big driver of the fact that when you can't offer that treatment or you have to think of an alternative, then you start thinking of a rational way of choosing another alternative. I think the next one also has become a big driver of the fact that people now start to question why this treatment and not the other, the third-party payer phenomenon, particularly the insurance companies. I think I'm not sure we go a month in our ophthalmology WhatsApp group without this subject coming up about what's happening with the insurance company, with the employers as well. The question, especially companies that offer medical schemes. Another driver is also just the need to start reducing risks. So especially when we start talking about in modern day things like cancer, some of the non-communicable diseases, diabetes, hypertension, they've become a public interest and people want to understand, so how can we reduce the risk of some of this? And invariably that starts to drive people into looking at research. And so whether it's social gatherings where you have these discussions or your patient coming to ask you questions, they are increasingly being driven to seeking interventions to reduce their risk. In the last 1 year, because of COVID, how many people have come up to you to ask, should we really be taking lemons and oranges and vitamin C, or what effect do they have if I don't take them? So people are now interested in reducing risk, and that invariably starts to drive people to ask questions that revolve around, so do we really know whether this is yes or no? There's also, generally, this is global, an increased managerialism. Again, in our own specialty of ophthalmology, we've started to see, push and pressure, trying to get us out of leadership in healthcare so that this can be left to other people to get involved. And so, their ethos is very different from a doctor. And they will start to question things. So, if an accountant now becomes the CEO of a hospital, they will start to question a lot of things which were probably taken for granted before. And also just an increasing... Hello, is that somebody speaking? Okay, so research also is beginning to make people aware of the fact that there are things we know and there are things we don't know. So what's the history of this movement of evidence-based practice or evidence-based medicine? Before this started, because the evidence-based medicine movement started in about the 1990s, before that, medicine was pretty much a very conservative profession, very tradition-based. In this hospital, this is what we do. In this specialty, this is what we do. In this country, this is what we do. A lot of tradition. There was a lot of anecdote. So people relied a lot on past experience to shape policy. You did this operation and one or two things happened that you were not happy with. And so you always advocate people should never do this because you had your one or two cases where something went wrong. So a lot of anecdotal use of anecdotal evidence, your personal experiences of the past. And so there tended to be a lot of passing on, because it was also, and even if you go back many years, the root of medicine was really in apprenticeship. So you really lived and worked with somebody and did the things they did. And to a certain extent, you didn't get much leeway in doing what you would like or in questioning what was being done. And some of that still exists today. People live here and go to a certain country and train in a certain institution. And forevermore after that, you always come and say, this is what they used to do in Guy's Hospital. This is what they do in, Australia or in India. And you tend to do what you saw those who taught you do. There was also a lot of theoretical reasoning from basic sciences, which seemed to disappear, but I think is also now beginning to re-emerge, especially with genetics. And we'll talk about that in another 1 or 2 slides. Then somewhere in the 90s, because of the drivers we talked about just before, then people started emphasizing on training clinicians on critical appraisal, the objective being to optimize clinical care. Somewhere in the background also, there were other things happening where, commercial interests were now beginning to become a reality. So the science of systematic reviews was born, Cochrane collaboration was born. I used to work with, I was trained by the Cochrane Eyes and Vision Group and still work with them as an editor. It's a pro bono, not paid position. And that movement now began slowly, and a lot of publications and training went out. But again, with every new thing, because people are always observing and evaluating, they started recognizing some limitations. So originally, the beginning of evidence-based medicine was purely underpinned on basically research evidence. So people started saying, but you also have to listen to patients' values and preferences. You also can't ignore clinical expertise. So there has to be some shared decision-making between the patient and the clinician. And so the definition that I gave earlier metamorphosed out of that, because initially we said we can't just rely on evidence alone. And slowly with time, again, there's been strong developments in setting methodological and publication standards. And there are some editors, especially somebody called Richard Horton, who used to be the editor of The Lancet, who are fairly vocal about some, biased policies they thought were coming out of people like the WHO. There was an editor of the New England Journal. Her name was Maria Angel. I can't remember if it was Maria, but I know her surname was Angel. Fairly controversial, not controversial, but, she really did speak out about what she felt was a compromise of standards. So now there's a lot of emphasis on, standards of publication, standards of, so when we teach people now critical appraisal, if you appraise a trial, we say, there's a certain standard way that a trial should be published. If you want to critique a diagnostic test study, there are now standards of what should be in that publication. The other thing that in parallel grew out of this is just an emphasis on producing trustworthy clinical practice guidelines and constantly updating them. And I should have underlined updating them. It's not enough to just write a clinical practice guideline. We must update them. There's even a standard for writing clinical practice guidelines. So, this emphasis started. I think in our setting, I've been in groups where we've written clinical practice guidelines. And quite often, even the funding of the process, there's very limited money available. So some of the standards, for example, include a guideline should have an edition. A guideline should have references. A guideline should even have critically appraised studies, evidence being cited. But we're never able to do all that because you're limited in even how big the guideline can be and who uses it. So back to the question of, so do we agree on what constitutes evidence or good evidence? So this is just a short list of some of the types of questions we have to deal with, whether you're evaluating a diagnostic test or even you want to look at the prevalence of a disease. What constitutes good evidence has to be the study that will give you the best information. And so on the right, I've shown different study designs of the types of studies that can be used to answer the question on the left. I don't think I want us to dwell too much on this. We've talked about it before, but there is what would be considered a standard for good evidence. So, if you're using, for example, you want to look at prognosis, this was what a cohort study would be, what would be considered good evidence, or a case control study, and perhaps some case series. But you wouldn't go and say, I did a cross-sectional study and I think I found certain people who are on this treatment were faring very badly. It may just be a chance association. So I will not dwell too much on this one. We've talked about this in previous years. But having said all these things, what are the challenges that are facing us? Despite all the best evidence available, there are a few challenges. And when I say us now, I'm thinking in Africa and particularly in ophthalmology. One of the challenges becomes often translation of the trial results to your patients. Just because a certain effect was observed in a trial population, how easy is that to translate to my patients? We all know that the kind of patients who get enrolled on trials are really people who are very compliant to the treatment, compliant to follow-up visits. So how close are those to the kind of patients I see every day? The other challenge also now from the producers of the evidence is a typical systematic review just takes too long to complete. To do a Cochrane review takes about 18 months, and it's usually 18 months to 2 years before it's published. It's actually a research project on its own. And I remember feeling very discouraged when some people thought systematic reviews are just copying other people's research. It's nothing like that. The other challenge now coming up in this day and age is genetics and individualized medicine. You see, when we do a systematic review of many trials, for example, or of a particular condition in the world, we now amalgamate data of a huge population of people and say, because of this huge population, for example, we think the average effect of this drug is X. And so we should be able to treat everybody using this drug. But now we are all beginning to see a huge growth in genetics. Everybody wants to find the gene responsible for this, the gene responsible for that. And if you manipulate this gene now, you can be able to offer this. So there's a whole new thing growing up called individualized medicine, which completely goes against making a decision for an individual based on what was found from a big population of people. People are now saying, that's not me. My genetic problem is this, so this is what I need. And, we can have a discussion about that because that has a huge potential to obviously treat well some very rare diseases which never got attention before, but also high costs. There's also a wide variation in the implementation of evidence-based practice. Some people believe in this, others don't. I did a trial using 5FU. It's difficult to get everybody to accept to use 5FU. People would rather use, different things or nothing at all. So we although there's evidence available for some things, there's a lot of variation in the implementation for many reasons. The bigger challenge I feel is actually distortion of the evidence-based brand. There are many people who like to throw in the word evidence-based, just like people like to do some studies and say, if you throw in the word randomized trial, that makes it sound like good research. And a lot of this distortion is actually by vested interests. That thing is also becoming a huge problem, especially in clinical research, where increasingly drug and medical device industries are setting the research agenda to the point where, they even decide what constitutes a disease so that you call something a disease and start creating things that can treat it. And the last one particularly, emphasis on patentable products. Everybody's looking to create a product, which, is good because sometimes some things are needed. But I think it's also beginning to relegate some things which are not necessarily patentable. If you change the surgical technique of doing one operation and modify it to something else, that may be a good trial to do and a new technique that may be very useful for patients. But a new technique is not a patentable thing. So you're not going to get even the funding to do that study. And even if you do the study, it's not going to generate much interest. So if you look at whatever is usually in the news over the last 2, 3 to 5 years, the emphasis is on a patentable product, COVID being the biggest example. There was a lot of debate, and it really still continues, about some old drugs that have been in existence for a long time, and all kinds of claims that this and this can be used and it's effective. But we all could see that the emphasis on a new vaccine, because that's a patentable product or something that you can economically benefit from, seems to be really what gets prominence. The other thing that has really been a challenge to this whole practice of evidence is the medical journals. And Richard Smith wrote this article in 2005, and he accused medical journals of really being just in cahoots with pharmaceutical companies. And it's an interesting paper to read, because some of the things he cites is, for example, journals will publish trials of drugs against a treatment that is known to be inferior so that they can appear superior, or trials of drugs against a low dose of a competitor drug so that there is a clear difference and one drug seems to win the day. Trials of drugs against too high a dose of a competitor so that you make your drug seem less toxic. Trials that are too small to show differences from competitor drugs, so that you can say our drug is as good as drug X, from company whoever. The use of multiple endpoints is a very common thing you'll find in papers in a trial, and then you select for publication only those endpoints that offered a favorable result. People do multi-center trials, but they only select for publication results from the centers that showed a favorable output. So if a certain center didn't show what the rest of you showed, and there's no reason really for doubting the methods, just put that away. The rest of us will never know because we only see what is published. Conducting subgroup analysis is a very common thing for people to do, and select for publication only those analyses that are favorable. And you will see drugs being sold on the basis of what was really a subgroup analysis, not the primary objective of the study. Presenting results that are likely to be impressive. So the way you phrase your result, for example, a reduction in relative risk may appear very impressive. The risk of this disease was reduced from 50% to 30%, but the absolute risk is really reducing a rare disease from 0.1% to 0.05%. So the absolute risk is not impressive, but the relative risk sounds really nice to say we reduced it by 50%. That would make a very interesting paper to read for anybody interested. Then, there's also been publication, and I only could pick a few, that evidence-based medicine is suffering from biased trials and selective publication, because you see, we've just said that it means looking for the best available evidence. This is published evidence that you're looking for. But if the evidence is bad or is biased, then we have a problem. So some of the things that have been found in a lot of these studies is overpowering of trials, so that small differences become statistically significant, setting inclusion criteria to select those who are more likely to respond to treatment, manipulating the doses of both intervention and control groups somewhere midstream, the use of surrogate endpoints, selectively publishing only positive studies. And this was particularly so, according to these authors, in industry-funded studies. Industry here referring to the pharmaceuticals and the device manufacturers. So there's really a crisis in evidence-based medicine. That quality mark, we've talked about it being disturbed by vested interests. The other challenge also is that the volume of evidence is becoming unmanageable. There are so many new articles published. There are so many new journals. I'm sure many of you have received emails from some journal you've never heard of soliciting papers. So the volume of evidence, good and bad, is really growing at a fast rate. There are so-called predatory journals that are now all over. The other thing also is that statistically significant benefits may be marginal in clinical practice. So even though something looks statistically impressive, in clinical practice, the practitioners don't think it makes a huge difference, and neither do the patients. This might be a repetition because I said it earlier, but care that is management-driven rather than patient-centered, making policy decisions that are not necessarily in the best interest of the patient. It's really management. This is what we'll do from this time going forward by a particular insurance company, by an employer. We've talked about technology-driven innovation, only patentable developments are of interest. The other thing which we don't think about much, but is a reality, is evidence-based guidelines. Because of the nature of trials tend to focus on a particular disease, on a particular type of patient. But the reality is, especially in ophthalmology, most of our old patients with cataract or with glaucoma also have comorbidities, diabetes, hypertension, and a lot of other, arthritis. So in a patient with complex comorbidities, which guideline do you apply? In fact, there's probably not going to be a guideline that deals with a comorbid patient, because those types of patients will generally not be included in trials. And so just, using the Cochrane assessment of just the risk of bias, because this is a huge subject, a lot of trials can be biased. And the bias can start right from randomization through the conduct of the study, people, the protocol deviations, from missing outcome data. Some patients don't come back for data collection, others, some data is available and some is not. But particularly that last one, the bias in measurement of outcome. People select an outcome that is likely to give a result, and we are going to talk about an example of one. And I've just picked it because it's something that we've had a discussion about in our journal club in the department. So biases in outcome measurement can be because of a method of measuring the outcome that is either not considered appropriate, or the measurement or ascertainment of the outcome differs between the groups. We are not sure who the outcome assessor is. Is the outcome assessor the same person who was offering the treatment, so he knows who was on what? They're blinded or masked to their assignment. Is the outcome likely to be influenced by knowing beforehand what the patient was on? Sometimes it is, sometimes it's not, and sometimes it's not possible to mask the assessors. But you need to describe in your article that this is what we did to reduce that kind of bias. So that's just one example. And I want us to think of this Antivedic trial that we all know about, that compared the three main anti-VEGFs that are used for diabetic macular edema in the world today. And I don't want you to get too engrossed in that long, busy slide. I just wanted to focus on the primary outcome. The primary outcome of these trials was the change in visual acuity from baseline to 1 year, adjusted for baseline visual acuity. So note, it is change in visual acuity. So at 1 year, when they compared, this was the study published in 2016. When you compare the three drugs, for everyone overall, you could see that generally there wasn't a big difference at 1 year, which is 52 weeks on our extreme right. The confidence intervals are overlapping. So the bars you see here are confidence intervals. And you can see at 1 year, the outcome, and note the outcome was actually visual acuity letter score using the ETDRS chart. There was no difference in those groups. But remember, the outcome was adjusted for baseline. So what they found is actually for people who had poorer vision, worse than 2015, then you could see that there was a bigger difference. You compare the 13, 11, and 9 to 18, 14.2, 11.8. So now there was a bigger difference. But for people who had fairly good vision or better vision than this, there wasn't a big difference. So this is obviously different. This drug has a much better outcome looking at that score than, there's no overlap between this one and the rest, but you can see that ranibizumab and bevacizumab overlapped in their outcome results. So that brings out this drug, aflibercept, to be more superior. And I'm not saying that these are fictitious results. This is actually published. So let's now go and ask visual acuity letter score. What exactly does that mean for me in Kenya with my patients? And I just wanted to pick this study to actually show you that some of the challenges of applying evidence-based medicine in our setup. That's the EETDRS chart, which was used in that study. And on the left, I have indicated the Snellen approximation because most of us use Snellen charts. Now, your typical Kenyan patient, if they're attending an eye care facility in Kenya, will most likely have a chart with this. So every line has 5 letters. So if I tell you that my vision improved by 10 letters, as letter scores is basically the number of letters you are able to read. So if there's a difference or a change from baseline to 1 year, and the difference between the groups is coming out to say 10 or so letters. 10 letters is basically 2 lines on this chart, because you can see there are 5 letters on every row. But 10 letters on the Snellen chart could simply be the difference between, it's not 2 lines, but it's actually a 1-line difference from 624 to just about 636, because our charts have 636. If you look at the scale, depending on where you are here, your charts go from 6.6 to 6.9, or so this equivalent on the ETDRS chart is just about 6.9.5. So I think I'm trying to tell you that a difference, a number like between 11 and 18 or 19 sounds like a huge difference. But the difference between the best year, if you want to say, is 19 and about 11.8, say 12. We're talking about a 7-letter difference between this group and this group. So a 7-letter difference here is not even 2 lines. It's basically 5 letters and maybe 2 of the line above or the line below it. And so I'm trying to say that the outcome chosen for a study may not necessarily apply to your patients or to your setting. And is that an appreciable difference for the patient? So we are not saying these drugs don't work. Please do not misunderstand that. I'm just trying to say that even as we consume literature, we really need to be aware of, so what is the outcome that was used and how do we apply that to our patients? Later on, we'll be talking about some, the things that we could do to try and change the situation. So if you actually look at the real visual difference in the 3 groups from baseline to 1 year, you can see that the letter score here is 65. That means that patient could read 65 letters. These ones, after 1 year, they improved to 78 letters. So a difference of about 10 is what I was trying to show you, that is maybe 2 lines on the ETDRS chart, but on our charts, that's barely a line. And again, remember that, we tend to talk about visual acuity as something that is a standard notation to us. But what does that really mean for your patient? So the other challenge also in evidence-based medicine is, essentially who pays the piper calls the tune. We have a lot of strong influence from the pharma industry that's just growing by the day. And unfortunately, we as doctors go for as little as just a cup of tea. And there was this paper that was published in 2016 in JAMA, where the authors were looking at what is the influence of payments made to doctors in various forms on the use of anti-VEGF agents in the US. And so they looked at databases of the companies and also databases of providers, care providers, to see how much of these anti-VEGFs were being used. And you could see that people who are paid as consultants, in whichever way, that's about how much was spent in dollars. Spending it on education, you can see how much education was worth. Food and beverage, this for me is what I find notable. It's a huge cost compared to even your education. Other forms of compensation, travel, they pay for your tickets to attend conferences. So the issue was not in the amounts paid, but they were looking for an association between this and the drugs. And they actually did find there was a positive association. As the payments increased, so did the use of particularly these 2 anti-VEGF agents. And the last one you might find laughable, that the threshold for doctors to increase the percentage of their drug use was ranging between $1 and $25. And this is in the US. So, what's $1 to $25? Those doctors were more likely than the others to increase their use of these two agents. So having said all these things, what needs to change, particularly in our setting? I think these are just proposals, and it'll be interesting to hear discussion. We need to start addressing problems that are a priority in our world. And I'm not saying, for example, some of the studies I've quoted are not relevant, but you would need to do that study with your patients with a different type of visual outcome in mind, and even a different perception of what's their quality of life. So although there may be a lot of evidence available, there is still room for us to do much more to address things that our patients are concerned about, diseases that are a priority for us. We also need research that includes our populations. A huge amount of what we use in terms of drugs and devices were not tested with us in mind. They were not tested with our patients in mind. So we need to have those patients included, so that we can see what does this work as well as we believe. We also need to ease the difficulty of conducting trials in developing countries. Sometimes we are our own worst enemies. Just getting approvals to apply for a grant, getting approvals to conduct the research. When I was doing my trials, I had to get approval from the ethics committee. I also had to go and get approval because I was doing a drug trial from the Pharmacy and Poisons Board. I was complaining about that to somebody until I learned the other day that it's become worse. Everybody wants to have some money out of this. So, you have to go to the nursing council, you have to go to so many other groups just to be able to conduct a trial. We also need to have explicit discussions over why, when research is done here, it's often not published and it's not cited. I have read review articles and wondered, so how come you haven't cited some of the studies that we have done in this part of the world? So there's still a lot of, let me say, behind the scenes play and biases in even the consumption of the research, the little that we produce. We also, I think, need to start thinking of having independent bodies funding research and even applying to independent bodies ourselves. So I find, for example, when I worked with my colleagues in London, organizations like the Wellcome Trust and others like those who have been funding research for years, they're really professional at it. And it's a competitive process. You apply for the grant, they give you the grant if they think they've evaluated your work, and they let you do the work. But that's not the case when your work is being funded by the manufacturer of a potential drug or device. That's not the same when research is being funded by an NGO. So, typically the person who funds the study does not get involved in the studies. In fact, when you publish papers, those are some of the disclaimers that you put on the front page of the article, that the funder of this study had no influence on the design or conduct of this study. But here, because, our government and other organizations who would be fairly independent are not funding research, we are now having research funded a lot by industry, by NGOs, and by other groups, and they also become part of the research process themselves. So I think there needs to be room for independent bodies to fund research. Research also needs to be informed democratically. Both patients, care providers need to set the priorities so that you're not necessarily conducting research that's driven by somebody out there. I think this is a global suggestion. We need to have research rating scales that downgrade research with too much conflict of interest bias, not just relying on things like webometrics or, this is the equivalent of the followers on Twitter, and whoever has more followers seems to have better research. So we need to find some way of vetting a lot of this research. So in summary, I think we've talked about what evidence-based medicine is, what are some of the drivers of this concept, some historical developments, the challenges that have emanated from it, and a few thoughts on what probably needs to change for us to be able to improve our situation. Thank you very much. I will stop there and stop sharing, and we can pick up questions or
Okay,
comments.
thank you, Dr. Gichuhi. So we'll go to the questions. You can post your questions on the chat. I'll just go through some of the comments so far. Dr. Walia says, a great presentation of a subject not clearly understood for different reasons. So that's a positive comment. Dr. Muraguri says, this presentation is fantastic. So let's see more questions coming up. So maybe I'll just ask a question of my own, Dr. Gichuhi. Now, during it was a fantastic presentation. I loved that you gave us quite an in-depth discussion. I've learned some new words like diffidence, which I'd never heard of. Too timid to make any decision. Maybe there's a point when you talked about predatory journals. Maybe you can just tell us something about that.
You are muted, Dr. Gichuhi.
So there are a lot of journals who are not even indexed, say, for example, on PubMed. And you know, they're a need for business. And usually most of these journals, typically you pay for your paper to be accepted. And so they're in need for the money. The thing is, some of them really will publish what would be poor quality research just because you can afford to pay for it. And there are people who use them a lot, but they're called predatory because, you know, they come soliciting articles from you. And I'm not sure how much peer review goes into that process.
Okay. Thank you. So ideally, should you be paying to publish an article in a journal, or you're not supposed to?
Well, that's been an ongoing discussion. So, for example, because the journals really need to make money to keep themselves running. Yeah. Some of them, once your paper is accepted, they will demand a publication fee once the paper is accepted. Some of the other journals are very easy about, it costs so much to get a paper published, so you almost kind of pay upfront. There are people now beginning to push back against that. So for example, if the Wellcome Trust funds you to do research, one of the requirements is that that paper must be freely accessible to everybody. And so in the grant, when you apply for the grant, they actually do include money for you to pay publication fees. Because again, research that is not read is useless. You also can't expect it to be free because, you know, how will these people work if they're not being paid for it? So subscriptions is what drives. So a lot of journals depend on subscriptions by big institutions, by government organizations, by academic institutions and things like that. But, you know, in our setting is different. So many times you're not even able to pay for those journals. So yeah. No rules or hard and fast rules. Should we pay? Should we? It doesn't mean that, you know, it's price.
Okay. Thank you. Let's see. We have more comments here. Professor Kamirimurio says politics also influences evidence-based medicine. I don't know what you have to say about that. It's correct. Yeah.
That is correct. That is
Dr.
correct.
Kamere says, thanks for the great presentation. I particularly liked the points around us conducting research relevant to our populations and not remain status quo with largely Western-based research. Yeah. Do you have anything to say about that Western-based research as opposed to local research?
I'm sorry, just say that again.
So Dr. Kamere said, thanks for a great presentation. I particularly like the points around us conducting research relevant to our populations and not remain status quo with largely Western-based research. So I guess she's talking about local research versus Western-based research. Yeah.
So I've worked a lot with people from the US and UK, and I think now it's not so much saying our research versus Western research, because the reality also is that there's also an increasing awareness among them that you can't conduct research in that part of the world without including the rest of the world. So there is now a greater, not a push really, but there's an increasing awareness about the fact that we need to be included in studies. So it would be research that is done, multi-center studies that include African study centers. And that for me is what I would suggest is the way to go, so that your data is combined with data from other places. But that has to be something that there has to be some common understanding. We can hardly finance healthcare services, so we can't really count on having even money to be spent on research. Yeah. And yet sometimes I actually think when you don't have the money, you're the person who really needs to shop around for what makes a difference for your little money. If you go shopping when you have no money, you're more likely to window shop a bit more because you want good value for your money than the person who has a lot of money in his pocket and buys at the first shop they come across. So for me, I've always felt because we don't have much money to spend on research, on health services, we therefore should be willing to spend a lot more on research to be sure we are really getting what is of value.
Okay. Thank you. Dr. Walia says, political goodwill and employer goodwill plays a huge influence in any work done in our country. Often they can almost dictate the outcome. So that's a comment. Yeah. Prof. Kiage asks, what, in your opinion, is the greatest threat to evidence-based medicine in the current time?
He's asked for my opinion, and I think just looking at what is going on, in our setting, I think for me that the greatest threat to evidence-based medicine actually is not even bad evidence, it's just the lack of evidence. We make a lot of decisions not based on any evidence available, and particularly where somebody else is paying. So if a lot of our services are basically being funded by NGOs, and even in our own professional setup, in the services, it's the NGOs. In our professional setup, I think it's actually the pharmaceutical industry. These very CME platforms we have are paid for. And sometimes I ask, why do you charge subscriptions that can't be able to run your service? Because ultimately, to me, is the things that are compromising us the most. It means also that government has no incentive to get in. County governments now, I've had people saying, I went to see the county, person in charge of eye health, and I gave a list of things we need for ophthalmic services, and they were saying, oh, but I've had Fred Hollows or some other organization can give that. And I'm sorry to mention them, but they're all there. It's not just that one. So that as a group, to me, is one of the biggest threats, because if you're not having to pay for anything, then you just do what is brought. And I'm not sure this is the right way to do this. I hope that answers Kiage.
Okay. Dr. Oenga says, thank you for the presentation. What is your opinion on having an institution like NICE that evaluates interventions and decides what is offered by the NHS in the public health sector? Will a similar approach work in our setting? Specifically, what is supported by NHIF? I don't know if you understand that question.
Yes, I do. It's actually a very interesting point. Yeah. And you see, NICE works together with NHIF, not NHIF, but with the NHS. NICE is the National Institute of Clinical Excellence in the UK. They basically do a lot of systematic reviews. They set standards for guidelines and all that, and then now advise the National Health Service that we have vetted this you can pay for, because the NHS pays for a lot of the health services. And so that only works in the situation where the person paying is the one looking for the information. Now, unfortunately, in our setup, our own NHIF, we are always complaining that I billed, I didn't get approval, I billed and didn't get paid. So, the NHIF is doing a lot to improve, but I think that will only work in the situation where the NHIF is actually the main financier of health services in the country. Then that kind of person can afford, then an equivalent institution to NICE will have somewhere to go to say, you can fund this, you don't need to fund this, it is not effective. But in the current situation we are at, where majority of the healthcare funding in this country is actually out of pocket, people pay for themselves. Even if you say you have an institution like NICE and produce guidelines that say this and the other, who is going to be interested in following them? You're not paying for them anyway. So we need to run that in parallel. The funding, the evidence, and the guidelines and practice, research, that needs to run together.
Okay. Thank you for that. Dr. Nyakagwa says, a very clear, easy to follow presentation, indeed a great presentation. So that's a positive comment. Dr. Godfrey Nyaga says, we need local solutions for local problems. Most of the yardsticks used to judge is from the West. That's similar from the previous. Anything to say about that?
Most yardsticks used, yeah, because that's what we were saying earlier, that they funded research, and the drive is actually commercial, is not something else. So they want to look for where the problems are in Africa so that you can find a product to sell to them. But that's beginning to change. I also have to say that. I've worked with some people in the UK who are, I think, for example, I'll just give an example. I've now been in 2 projects where they actually insist that the UK PI must have a Kenyan PI of equivalent level, and some of the money must go to the developing country or third world or LMIC, whatever word you want there, so that they can also be equitably involved. So that's starting to change. But yes, a lot of times in the past, yardsticks that have been used to measure problems are basically Western driven.
Okay. Okay, Dr. Patrick Nyaga says, thanks for the great presentation. Dr. Inoti Murithi says, insightful presentation and very relevant topic. Thank you, Dr. Gichuhi. Dr. Sitati asks, what is your advice on institutions from the West running research on sub-Saharan Africa and requesting information through surveys or emails? What should be reasonable demand before giving information, e.g. as a country or institution? Co-authorship acknowledgements.
That's a very good and important question. And for me, I would even raise the bar higher, because to me, being offered co-authorship or acknowledgement can't be used as a basis for saying, now I'll give data if you'll include me in the authorship. Because, and for me, I'm really thankful about what's happened now with the new awareness on data security and data protection in this country. And now we know we appointed a data commissioner. Any form of data sharing will now be regulated, including the sharing of routine is routine data, hospital data, regulated, so that it's not just shared freely. And those for whom you share data, some of the ethical things are that they must be involved in knowing where their data is going. So that's going to change. And so for me, I think it's been manipulative to tell people that I will only give you a grant if you give me data about your hospital. I will only involve you, or they don't even involve you in the studies, and they want to have mobile devices collecting data somewhere in the rural places, and the data is immediately uploaded to cloud and all that. So that globally has now become a big thing. Is data about our patients sitting on the cloud something that is ethically acceptable? And now there's a lot of pushback on that. And I think you'll soon be seeing legislation coming about such things. And I think for me, it was just the best way to do. I think it can be easily abused or manipulated. Even in exchange for publication, that is just you wouldn't do that. You wouldn't be able to get data from those countries in the method with which they get data from us. So that to me is about equitability. It's about doing what is right.
Yeah. Okay. I see that there are no more questions here. We're through with all the questions. So thank you very much, Dr. Gichuhi. That is a very informative talk. We've learned quite a lot about evidence-based medicine, and that intersection, I think, was a take-home message for me. The first slide that you showed where it had patients' values interlocking with the best evidence and clinical expertise, bringing it to evidence-based medicine. So thank you very much. And I'll hand over back to Dr. Kalu.
Thank you very much.
Thank you very much, Dr. Gichuhi. That presentation was awesome, and we've learned a lot. And it still is good to keep on being reminded that what exactly are we saying when we say evidence-based medicine, so that we just don't throw the word around and we actually do what is proper evidence-based medicine. And thank you for highlighting those biases. I think we sometimes might overlook them and not take them into consideration. Some of them don't look like biases until someone points out. So this was a very good and enlightening presentation. Thank you, Dr. Wanyonyi, for moderating for us so wonderfully. And thank you everyone for all your comments, being present with us today evening, giving us your comments, questions. You've made our day successful. Thank you very much. I will just, sorry. So we don't have any other presentation today evening. So I'd like to thank you and hope to see you again here in another 2 weeks for another enlightening session whose topic we shall communicate in due course. Asanteni sana, have a good evening, and please feel free to leave at your own pleasure. Thank you.